Hello, and welcome to our Behavioral Health 911 event. I am Melissa Silva, the Executive Director of the Louisiana Mental Health Association. Thank you for joining us today for this important conversation. We are grateful to our community partners, especially the local governing entities that have worked with us to produce this event. LAMHA also appreciates Louisiana Department of Health Office of Behavioral Health for sponsoring today's and 9 other events across the state. We also want to thank our panel for sharing their time, expertise, and their lived experience. Over the recent years, the Louisiana Mental Health Association has worked with our partners to identify critical issues in our local communities and our state. And in response, we offer these informative discussions on behavioral health that affect both our youth and adult populations. As our state continues to work to improve programs and services for those most in need, Louisiana Mental Health Association stands tall in our efforts to educate and advocate for those same individuals. Conversations like the one today are a small but a pivotal step towards breaking the stigma surrounding mental and behavioral health and seeking the help one may need. Before we start this discussion today, I would like to highlight a few of our spring events. Louisiana MHA will be bringing you our virtual public policy on March 2nd, 2023. This is to make it easier for those of you to attend across the state. Our 6th annual conference will be held on April 25th through 26th, 2023, and will feature live virtual sessions. Finally, our Behavioral Health Day at the Capitol will be held on May 4th, 2023. More information on all of the events will be forthcoming, but we ask that you save these dates on your calendars now. Today's panel has been pre-recorded so that we eliminate the risk of technical challenges. There will be a live Q&A after the presentations and the speakers will join us. Please put your questions in the chat. You can add them now, or you can wait till the live Q&A section. Following the event, you will receive evaluation. Please help us improve these events by completing that. Again, I want to thank you all for joining us today. I hope that you learned much from our panel of experts. Have a great day.
Hi, my name is Tanya McGee, and I'm the Executive Director for Imperial Calcasieu Human Services Authority. At MCAL-HSA, we have the honor and the privilege to work with individuals who have been diagnosed and are seeking out treatment for behavioral health disorders. And we also, in our Developmental Disabilities Division, have the privilege of serving those folks who are diagnosed with a developmental and/or an intellectual disability. We know that as an entity and an agency that we're unique in that because we serve both of those populations. And in working with community providers and partners like yourself, we have identified that there truly is a need to have people educated and trained in working with individuals who have co-occurring disorders, who have both of these disorders. So they may have a developmental disability or an intellectual disability coupled with and alongside of a behavioral health disorder. Today, we wanted to be able to provide, in conjunction with our partners with Louisiana Mental Health Association, to provide a training for you guys to start educating both sides of the fence, behavioral health and DD, on what that other disorder looks like. So today, you're going to hear from a handful of panelists who are going to provide you with a great deal of good information. And again, I really hope that this scratches the surface, because we are seeing this co-occurring population more and more in the individuals that we serve. And I think it's important for us to make sure that we have and we offer training to our providers and our staff and individuals in our community on how to appropriately work with this population. So I'm excited to have all of you guys. I hope that you guys are familiar with Imperial Calcasieu HSA, and if you're not, check out our website. But today is going to be a good day. The next hour and a half you're going to spend with these trainers is going to be very informative for you. And again, I hope this really scratches the surface as we move forward to building treatments and services that are geared toward helping this population. So I don't know about you, but for me, and doing this for you is the best part of my day. So I hope that after this training session, that'll be the best part of your day too. And again, moving forward as we work to build programs and services for this population. So I really wanted to welcome you guys and hope that you guys have a really great training session. Thanks, everyone.
Hi, everyone, and thank you so much for joining this important discussion. My name is Tatiana Gonzalez, and I'm the Advocacy and Education Manager for the Louisiana Mental Health Association. Today, we're going to take a look at Louisiana mental health screening data. This data was made possible by Mental Health America National. This data was recorded during July 2022 through September 2022. During this time, 7,250 screenings were conducted. This was an increase of 2,215 screeners from last quarter. Now let's dive in and take a look at what the data shows. As you can see in this map, these are the top 10 parishes that participants screened in. The first was Jefferson Parish, followed by East Baton Rouge, Orleans Parish, Other, Lafayette Parish, Ascension Parish, 7th was St. Tammany Parish, 8th is Caddo Parish, 9th was Calcasieu, and the 10th was Ouachita Parish. Please note that screeners self-identified with these parishes. Mental Health America did not determine the parishes that the screeners were in. This graph shows the top 3 mental health conditions that participants screened for. The first was severe depression, followed by ADHD likely, and the third was positive bipolar. The Louisiana Mental Health Association wanted to dive deeper and look at the demographics of our screeners. 60.57% of our screeners identified as white/non-Hispanic. Our second largest race of our screeners was Black and/or African Americans at 22.21%. On our right, you can see household income. According to our screenings, 27.59% reported having a household income of less than $20,000, and 50.09% reported having a household income of less than $40,000. We also wanted to see what gender was taking our screenings the most. As you can see here, 69.06% of our screenings were women, followed by 26.27% who were men, and 4.67% of our screenings identified as other. On our right, you can see what age group screened the highest. 61.01% of our screeners were 24 and under. This really highlights the need for mental health services in this age population. Moving on here, we wanted to ask our screeners if they had ever received any form of support or treatment for a mental health problem. Unfortunately, 54.01% of our screeners had never received any sort of treatment for their mental health problems. On our right, we also asked if they were currently receiving any treatment or support. 53.32% of our screeners said that they were not currently receiving any support for a mental health condition. Below, you can see that we asked if they had any form of health insurance. 84% of our screeners said that they did have some access to health insurance. We wanted to dive in deeper and see what special populations made up our screenings. As you can see here, students were the highest screeners at 2,322, followed by members of our LGBTQ community at 1,197, and our third highest special population were trauma survivors at 1,159. 4,678 people who took our online screening described themselves as either being a student, a member of our LGBTQ community, or a trauma survivor. We also wanted to ask if they had any form of general health condition. Oftentimes we know that mental health and physical health are overlapped. As you can see here, 337 screeners had arthritis or chronic pain. This was the most prominent health condition identified by our screeners, followed by reproductive health concerns like endometriosis at 287 screeners. Our last highest were screeners who had diabetes at 164. Lastly, I wanted to end by highlighting one of the Louisiana Mental Health Association's programs, the Fisher Project. The Fisher Project is a comprehensive suicide follow-up and recovery support service. It is a 6-month peer-to-peer case management program that is at no cost to the participant. During this time, participants are screened for suicide risk, and it's an ongoing assessment. It's aimed to create safety planning and means restriction. It also offers transitional care and a warm handoff to either the treatment or community. If you're interested in learning more about this valuable program, please contact Fisher Project at louisianamha.org or give us a call at 225-960-6800. I hope that you enjoy the rest of our presentation today. Take care.
I'm Dr. Brandy Kelly with the Office for Citizens with Developmental Disabilities. I have worked with individuals who have intellectual and developmental disabilities and behavioral health needs for over 2 decades. And I'm happy to be here to talk with you about understanding better what behavioral health needs may look like in individuals with IDD and how we can make some minor modifications in assessment, diagnosis, and treatment so that they can access and benefit from the same types of treatments that individuals without IDD access and benefit from. Despite the fact that there was a time when individuals with disabilities were thought not to be able to experience other co-occurring behavioral health conditions, it's well established at this point through lots of research and clinical practice that in fact individuals who have intellectual and developmental disabilities have a greater risk of developing behavioral health conditions compared to their peers who do not have IDD. It's commonly accepted that over 1/3 of individuals with IDD will experience behavioral health symptoms. And since COVID, depression and anxiety rates have increased pretty significantly for individuals with intellectual and developmental disabilities. Individuals with intellectual and developmental disabilities also experience very significant trauma. And estimates are that 80 to 90% of individuals who have IDD will experience trauma in their life. Many individuals will have multiple trauma experiences, and over half of these individuals currently never access treatment for the trauma or the trauma response. If you look at data specific to our state, you can see that it coincides with what we would expect. In our most recent National Core Indicator Survey data, which is a survey done by the National State Directors of Disability Services Group, 25 to 35% of adults experience a formal behavioral health condition. 11% of youth have a formal behavioral health diagnosis. And 50 to 68% of adults struggle with some sort of self-injurious or destructive behavior, while 43% of youth struggle with self-injurious or destructive behavior. If we look at adverse childhood events data for individuals in Louisiana, we see that 90% of the individuals that we serve in the OCDB system experience adverse childhood events, and more than half of them experience multiple events. So again, you can see some pretty significant rates for behavioral health conditions and even greater rates of trauma that tell us that individuals with intellectual and developmental disabilities do experience these symptoms and problems, and they will need access to assessment and treatment. Because some developmental disability conditions do come with some cognitive and communication challenges, there could be modifications that need to be made. But these modifications do allow for the process of assessment and treatment to continue. I'm going to talk a little bit about some things that we can do when someone has some communication and cognitive differences that will allow you to feel more comfortable providing assessment and treatment services. We want to be sure that we allow sufficient time for the person to process and respond. So you may need to pause a little bit more. Don't rush the person, and don't attempt to finish what you think they might be saying. Don't assume that they're not responding. Give them a moment and let them have the opportunity to process the information and respond in a way that works for them. Be sure to use easy to understand language. As clinicians, we can often use clinical language, big words, compound sentences, and we really just want to keep it simple. And if we can make that adjustment, most often individuals will have a better understanding and they will be able to participate and respond. You want to focus on one concept or idea at a time, or one question at a time when you're doing assessment and treatment work. It's going to be hard for some individuals who have some cognitive or communication challenges to keep in their mind more than one concept or idea at a time. You want to be sure to use a blend of open and closed-ended questions. Some open-ended questions may be hard for people to answer if they have cognitive and communication challenges, so you may have to probe a little bit. But if we just use simple yes or no questions, sometimes the individual will end up responding in a way that is biased towards what they think the answer may be or what they think you want the answer to be. You want to be sure to use multisensory input. You want to use visual cues when possible, gesturing, role playing throughout assessment and treatment when that's appropriate. You also want to be sure that before you begin any assessment or treatment activities, that you know if the individual uses any specific technology to communicate, if they use sign language, and that you have appropriate accommodations and they have access to any of that technology. And then you want to ask if there are any other unique communication needs you need to keep in mind, and make sure that you adapt your communication style and efforts so that the individual can participate and respond. We'll talk a little bit specifically about assessment and diagnosis considerations. There are two manuals that are available that can help in looking at diagnostic modifications. The National Association of Dual Diagnosis publishes the Diagnostic Manual for Intellectual Disabilities. They are currently on the second edition. This manual is tied to the DSM-5, and it helps with some general assessment tips, but also looking at every diagnostic category and identifying the things that you might modify and considering the number of symptoms, how symptom presentation may change a bit, so that you can feel comfortable making a diagnosis. The diagnostic criteria for learning disabilities is published by the Royal College of Psychiatrists, and it is attached to the ICD system. So it is often a useful resource if you're trying to make sure that you are assigning the diagnostic coding so that you can bill appropriately. So these are two resources that are available and can help you in making any diagnostic determination. When you are doing an assessment and you are looking at diagnostic considerations, individuals with disabilities can participate in mental status examination questioning. You may have to make some modifications. For example, someone's appearance might mean less if they are less independent in dressing and grooming. So you will need to know a little bit about the person's ability to do certain things for themselves each day. More complex areas may need to be adapted. So you may ask the person to count backwards instead of doing serial sevens. You may ask them to remember an object you showed them earlier instead of remembering 3 words that you told them earlier. Our Office for Citizens with Developmental Disabilities has some modified tips for completing a full mental status exam, and I will share some links at the end of the presentation so that we can make sure you have access to those. But know that you can conduct a mental status examination with someone who does have cognitive and communication challenges. And there are some simple modifications that can be made so that this is a useful part of your assessment. And remember that this can often help in looking at not only the initial diagnoses, considerations, but it can help as you are looking at symptom changes and differences in presentation as you are engaging in treatment with someone. For an individual with IDD who has some co-occurring communication and cognitive challenges, observations may be a necessary and useful part of assessment, more so than it may be with someone who does not have an IDD with cognitive and communication challenges. Sometimes this will give you some indication of possible signs or symptoms of mental health conditions. So you may notice that someone seems avoidant. Maybe they look a little worried or afraid. Maybe they're shaking or pacing. You may see some mood changes that help you indicate where you want to explore further in your assessment. Observations can also help when you're looking at convergence of information. If the person has some trouble communicating, you'll want to be sure that what they are attempting to share with you verbally or in whatever manner they communicate is also matching with the observations you're seeing of their behavior and their mood and their interactions with anyone else who may be present with them. Individuals with disabilities will often have people in their life, whether it is family or staff, who help them every day, sometimes throughout their day. And because of that, there may be a necessary inclusion of other people throughout the assessment process differently than if the person didn't have a disability and didn't need this assistance. So you're also going to have to think about how you speak with the family and staff and include them in the process, and how you balance gathering information from them with also still making sure that you are gathering appropriate information from the individual. So you'll need to think about how you include other people, how you balance that with the information the individual is sharing with you. Where is information coming together and consistent versus where there might be disagreements and gaps and you need to explore further. Be sure that you don't assume that the information other people give you is automatically the accurate information. It may be a viewpoint and it may give you information that is useful, but you absolutely want to be sure that the person's contribution to the assessment is also taken as a priority. Once you can complete an assessment with an individual and perhaps settle on a diagnosis, then you'll need to think about therapy and treatment. Individuals with IDD, as I mentioned at the beginning, can participate in the same types of behavioral health treatment that individuals with IDD participate in. Many individuals with IDD will be able to participate in treatment and therapy with no modifications. Not everyone who has an IDD has cognitive and communication challenges. Some individuals have a disability that really has primary physical impacts. And then even individuals who have some cognitive and communication challenges, they will differ in degree. So you can always start from the perspective of how you would approach treatment and therapy in general. When you believe that you need to make some modifications because someone does have some cognitive and communication differences, these are some common things to think about. You may want to think about how you need to adapt your session length. Some individuals will need shorter sessions because they won't be able to retain a lot of information. And you're going to reach a point where they've sort of maxed out what they can do in that one session. Or they may just have trouble sitting in a session and paying attention for a really long period of time. Individuals who have some unique communication needs or use technology or signing to communicate may warrant some longer sessions because it may take a little bit more time to have the dialogue and to benefit from the session. Lots of times individuals with IDD are going to need more frequent sessions and perhaps more sessions in number. It may take a little bit longer. They're going to need a little bit more practice in order for some of the skills that you may be teaching them and some of the coping strategies to really stick and be able to be used. You need to also remember that you may need to prepare the person for expectations in therapy. A lot of times the individual with IDD is not going to have self-referred themselves for your services. Someone else is going to sought services or treatment on their behalf. So they may have a different opinion and a different belief about their need for treatment. What is the identified problem may be different in their perspective than those who referred them. And you will need to keep this in mind and work with the individual on what their goal may be in therapy. You also want to consider using some visual agendas so that you can make sure that the person understands what to expect in each session and how the session will go. Remember that multisensory input and role playing can be especially important components in any type of therapeutic approach. Both cognitive behavior therapy and dialectical behavior therapy have clearly demonstrated effectiveness with some adaptations for individuals with IDD. And the most common adaptations are going to focus on more guidance by the therapist in the sessions, use of less abstract concepts, lots more practice and rehearsal, and often using role play, as I mentioned earlier. Our office also has some information on these modifications in more detail. And again, this will be available at the link that I will provide at the end of this presentation. There are some other evidence-based practices that are available in Louisiana, which individuals with IDD can benefit from when it is appropriate for their presenting condition. And you may or may not provide these specific evidence-based practices, but you may be assessing someone and needing to make appropriate referrals. So wanted to share this so that you know the types of treatment approaches that you can feel comfortable recommending, just like you would if you were perhaps assessing and recommending such a service for someone without IDD. Multisystemic therapy can be beneficial for individuals with IDD for similar types of challenges that multisystemic therapy might be recommended for someone without an IDD. The core components of MST are actually very consistent with many of the practices that we use in the IDD planning and support system, including looking at contextual variables and individualizing support, meeting the person where they are in their home, in their community. It's also important to know that the agency who actually certifies MST teams has MST ID certifications and MST ASD certifications for individuals with intellectual disabilities and autism spectrum disorders. There are individuals in Louisiana who have an IDD who actually do access and benefit from MST. So when it is appropriate, you can feel comfortable making a recommendation. The same is true for assertive community treatment. We have individuals in Louisiana who do use and access this service for the same types of issues that you might recommend them for someone who doesn't have a disability. There are times when behavioral consultation from someone with experience treating an individual with IDD and behavioral health can also assist the assertive community treatment team. And that can be accessed and provided, and I will share some information related to that near the end of the presentation. Eye movement desensitization reprocessing is also an evidence-based practice available in Louisiana that individuals with IDD can access and benefit from. Remember that in this particular therapeutic approach, there is not a high requirement for any significant verbal skills and interactions, so that makes it a type of approach that individuals with communication challenges can easily participate in. It is true that it may involve a little bit more direction from the therapist during the sessions for the individual's benefit. Trauma-focused cognitive behavior therapy is also available in Louisiana, and similar considerations in terms of modifications, as I noted for CBT, can allow individuals with IDD to participate in this particular approach. Triple P parenting is the final evidence-based practice available that you may want to consider when appropriate for young kids. There is also a Stepping Stones IDD certification available from Triple P. I mentioned that we do have some tools and tips available that can assist you as a clinician or as a clinic provider. These tools and tips can be accessed at the link here. We will make this link available to everyone participating. The tools and tips can be accessed in real time, and we update this link on a regular basis. It includes information on some of the modifications that I shared in more detail related to assessment and treatment. It also includes the mental status examination modifications. It includes some tools you can use to look at various types of trauma considerations and other issues for individuals with IDD, so that you can be sure to consider any unique considerations. It also includes links to purchase the DMID should you elect to do that, as well as to some white papers related to the evidence-based practices that we mentioned. I'm going to end my presentation talking a little bit about the OCDD Resource Center. The OCDD Resource Center operates across the state. These are a group of clinicians that I supervise who practice across disciplines. The majority of our clinicians are behavioral health clinicians. We do have access to allied health clinicians and nurses when there are multidisciplinary issues. The mission of the Resource Center is to build community capacity to support individuals with IDD and other complex needs. So we focus very much on individuals who have IDD and co-occurring behavioral health needs. We are not a specific clinic or a direct service provider in general. We are focused on working with clinicians and providers so that you can become more comfortable serving individuals with IDD and behavioral health needs. We are available for consultation to a treating clinician for complex assessments or treatment modifications, and that can include a treating team, as I mentioned, relative to assertive community treatment or an MST team. We also are available to provide more in-depth training, and we do our continuing education throughout the year on a variety of topics, including assessment and treatment for individuals with IDD and behavioral health needs. So we are available and we can be reached at the OCDD Resource Center webpage or at resource.center@la.gov. It has been a pleasure to present to you today. I look forward to our opportunity to talk as a panel. Thank you.
My name is Ashley McReynolds. I am a parent of a 16-year-old that has a diagnosis of an intellectual disability and also has a co-occurring behavioral health condition. I am a program director at the ARC of Louisiana, and one of my contracts is with the Southwest ADA Center located in Houston, where my focus is on healthcare disparities for the population, specifically with individuals with disabilities, including those with intellectual developmental disabilities and co-occurring behavioral health conditions. My goal with this contract is to identify disparities and barriers that this population faces, and then work with professionals, including physicians, nurses, social workers, psychologists, psychiatrists, individuals that would be treating this population, to bring awareness to the barriers and the disparities that this population faces, provide them with pretty common sense tips in communication techniques and simple accommodations and modifications that they can make to their practice to ensure that these individuals receive equal access and adequate services to improve their lives. So I spoke briefly about being a parent. My son Cooper is 16. He has a rare syndrome called Prader-Willi syndrome, and also suffers from a couple of different behavioral health conditions. He suffers pretty significantly from anxiety, and also has a diagnosis of bipolar. He has struggled these last probably 3 years pretty significantly in finding a provider who was willing and able to treat him. We've struggled with medications, just in general finding services, especially when we reach crisis level, and we're unable to secure a bed for him when he was really in crisis. So it's really become a priority for me for this population. And so I'm thankful for the opportunity today to get to share some of the work that I'm doing with you. So let's just first start with the mental health of people with disabilities. There's all kinds of studies out there that show that adults with disabilities, individuals, youth as well, experience mental distress far more frequently than those that do not have a disability. So you can see here in 2018, 32.9% of adults that have a disability reported frequent mental distress. And that is defined as 14 or more reported mentally unhealthy days in the past 30 days. So these individuals are spending about half a month at a time in mental distress. We all know that, with mental distress comes with extremely poor health behaviors. You utilize health services far more frequently, and most of those are more expensive because they're in emergency department settings. This affects, of course, chronic conditions and acute conditions, and really limits individuals in their activities of daily life. So prior to 1960, it was believed that individuals that had an intellectual or developmental disability were just not capable of having a co-occurring mental health condition. And they also believed that these individuals would not benefit from the same type of services that people without disabilities, when they went to receive treatment for behavioral health conditions, could actually benefit from. Some of the most commonly recognized conditions co-occurring are depression, anxiety, bipolar mania, and then psychosis and schizophrenia. While it is very much recognized that there is a very high prevalence of behavioral health conditions among individuals with IDD, there is very little known about the best approaches for the needs of these individuals and the challenges that these individuals and families face. So it is known that people with intellectual developmental disabilities are more likely to be impulsive. They're going to have several co-occurring medical problems, not just IDD and behavioral health. They're going to have several medical complexities. They are going to demonstrate challenges in any type of self-monitoring and self-regulation. They're also going to have difficulty with problem solving. They are going to have limited self-calming skills, and then also have limited language skills, which can make your everyday treatment for behavioral health conditions a little bit more challenging. So on top of just the behavioral health IDD co-occurring, there are also other risks associated with this population. They are at a much higher risk of having physical health conditions, which then can also contribute to an increase in the risk of other mental health conditions. They have for a very long time had their symptoms of a behavioral health condition being misattributed to their intellectual or developmental disability, rather than being recognized as a part of the manifestation of the actual behavioral health condition. This population also experiences much higher rates of physical and sexual abuse, which can then also magnify their vulnerability when it comes to behavioral health. So here's where we are today. Because of all of this uncertainty, unfortunately, it has led to the dependence of very outdated and honestly, just really bad approaches to mental health care for this population. It has led to the use of restraint and seclusion of these individuals, the overuse of psychotropic medications, which can actually cause this population to further struggle with anxiety and some of the other behaviors that come along with their specific mental health condition. It puts a very significant strain on any family support or natural support that these individuals receive, because they're left with very little services available in the community that are able to provide the proper supports to keep these individuals in their homes and in their communities where they want to be. So I have some Louisiana facts. According to our last census, our population is about 4.7 million. And almost 4% of that live with serious mental health conditions such as schizophrenia, bipolar, and major depression. So nearly 1 in every 5 adults. Compared to the rest of the US, we are higher. So we have 21.2% of adults in Louisiana with a mental illness compared to 19.9. And then when you look at our Medicaid population, there were in 2019 about 40,000 hospitalizations due to a serious mental illness, which is quite significant. If you don't know, there was a Department of Justice investigation that was done, and they found that the state was improperly relying on nursing facilities to serve individuals with a serious mental illness or behavioral health condition, instead of providing these services in an integrated setting that was most appropriate to meet their needs. So this led to the Department of Health entering into an agreement with the DOJ that was very specifically detailed and outlined all of the expectations regarding these activities related to those that were residing in nursing facilities, and also just our overall behavioral health service system. And it required them to develop a crisis system of care, which we did not have prior to this Department of Justice finding. When you look at just some more facts, we rank 45th in the US for access to mental health care. So that's in general, that's not specific to individuals with intellectual or developmental disabilities. That's the general population. When it comes to individuals with an intellectual developmental disability, that number is actually probably worse, probably might be 48th or 49th. There's a big reluctance for clinicians to see individuals with an intellectual or developmental disability. But we'll talk about ways that we can sort of break down the stigma around physicians not wanting to serve this population. But when you look at some further statistics, 61.8% of those that report having a serious mental illness, they report receiving absolutely zero mental health treatment in the state. So OCDD, or the Office for Citizens with Developmental Disabilities, does a survey every year. It goes out and it's referred to as the National Core Indicators. This data runs behind, so it's not that I don't have more up-to-date data, just the data coming in is delayed in reporting. So the most current data that I have is from 2018, 2019. And so these are individuals that have a diagnosis of an intellectual developmental disability. And in the adult survey, we had 25% of adults reporting a psychiatric disorder. 50% reported self-injurious behaviors or disruptive or destructive behavior. When we looked at the results for the adult family or the guardians who filled out the survey, 35% of them reported having a psychiatric disorder or diagnosis. 68% reported supports for self-injurious and disruptive or destructive behaviors. So they had a need for these types of supports, but were not able to find them. And for the child family, 11% reported having a psychiatric diagnosis, and then 43% reported the need for supports for the more serious behaviors. So overall, these are more statistics that were done in a different survey from 2017-18. And I don't need to go through all of the numbers, but you can just see overall the statistics and the prevalence of having a significant mental health or behavioral health challenge in individuals with intellectual disabilities is very prevalent. And unfortunately, the supports and services for these individuals are not available in the community, and they are also not available when a person enters a crisis situation. So how did we get to this, to where we are? Our previous administration started about 15 years ago when budget cuts were made, and the state closed the only 2 inpatient facilities that were available for inpatient treatment for these individuals. They were staffed with physicians, nurses, psychologists, other allied health staff that had the knowledge and expertise to provide treatment to these individuals. We had a stabilization unit, or an SU, and we also had a developmental neuropsychiatric unit, or the DNP. What's really needed now is, again, something specifically to treat this population, but we also need services across our entire continuum. We have to have better access to community-based treatment. Right now, it is very limited, and families report what's available is just not meeting the current needs of their loved ones. So some of the needed services are therapeutic respite. There are, I think, about 7 center-based respite facilities across the state. Unfortunately, these facilities are very hesitant in serving individuals that have sort of violent or destructive behaviors. So the one thing that is available for these families, these facilities are just not accepting this population, leaving individuals and families to struggle alone. As a family member, as a parent of a child that has very significant behaviors, I can tell you that we definitely struggle alone. We tend to hibernate in our homes out of fear of bringing them in public and having behaviors, people not understanding the behaviors, police and law enforcement not understanding the behaviors, and it really just becomes extremely isolating for families. What has also occurred is the state is actually paying to send individuals out of state. I know families that have gone to Kennedy Krieger. I know some other families that have traveled over to Texas Children to receive inpatient care and treatment. They are also admitting individuals into Pinecrest up in Alexandria. And that alone costs about, well, it's over $200,000 a year now, because we just don't have the proper supports and services for these individuals. We also have a very significant shortage in psychologists and psychiatrists, that just in general. And we also lack those that have the proper knowledge and expertise to serve this population. Okay, so when I've talked with parents, individuals with disabilities, the key issues that they always are bringing to the forefront is that our mental health professionals lack key knowledge about individuals with intellectual and developmental disabilities. The disability and the mental health care systems are extremely complex. They are not very flexible, and they often do not interact or speak to one another, leaving families having to navigate multiple systems to find, a continuum of care for their loved ones. When it comes to an individual having an intellectual developmental disability, these individuals report that they really struggle communicating effectively with their physicians. And when they feel like they're communicating effectively, they often report that they feel like the clinician or the physician does not, I guess, understand them in a way that they feel like they're actually being heard. So, and again, individuals that have a dual diagnosis, parents that have a young child or an adult that have a dual diagnosis, And then the other family members in that family unit always report feeling completely isolated, like they're alone on an island. And it's a direct result of the lack of understanding, the continued discrimination and stigma related to this population. So what are some of those barriers to the service system? I broke down the two service systems that this population receives services from. You have OBH, or the Office of Behavioral Health, and then the OCDD system, Office for Citizens with Developmental Disabilities. These systems have very little or actually no collaboration at all. So when you look at how these services and supports are different between the two, within OBH, the services and the supports are often short-term, based on acute onset of symptoms. Compared to the DD system, these services and supports are a continuum across the lifespan. OBH really only focuses on any type of psychiatric need. And the DD system, its emphasis is on direct support. So specific to the needs of that individual, related to activities of daily life. The OBH model, again, recovery model, medication, management and treatment. The DD system is very patient-centered and does offer some behavioral support, but not to the level that is done in the OBH system. Overall, between both systems, there is a lack of funding for services. I will say in this current administration, there has been an emphasis on the funding for services for people with disabilities and those that have an IDD. We are in a much better place than we were 8-10 years ago. I mean, significantly better place. We also find that even when families find a provider that is willing to serve this population, it is very difficult to find when that individual's only insurance is through Medicaid. There are a lot of administrative and just bureaucratic red tape that makes it very difficult for the family and the individual to access service without a lot of hurdles that they have to get through before they get into the door to receive the service. There is very much so inconsistent crisis procedures, and this causes a lot of confusion for individuals and their families. They will be notified about a procedure or about a support or a service available. But then when they actually get and explain, this is what my child needs, this is, their current issues, the provider may actually say, you know what, we just can't serve them. There is a very significant direct care worker crisis, which has put another strain on the system, and leaving individuals with intellectual developmental disabilities from receiving consistent support and care, which can also then have a negative impact on their behavioral health challenges. And then there's still a lack of accessible and public transportation. This has been an issue, especially in our rural areas, finding, whether it's medical transportation or, an Uber or a taxi or a Lyft. There aren't accessible transportation providers. And if there are, sometimes you have to try and plan for these trips months in advance. So just being able to access a provider is extremely difficult, especially in our rural parishes. So healthcare access, it is one of the biggest barriers for this population. The stats are staggering when you look at 1 in 3 adults with disabilities between the ages of 18 and 44 do not have like a general practitioner or an internist. They don't have that, yearly check-in. They don't have a provider like that. 1 in 3 adults report having unmet healthcare needs, strictly related to cost. And it can also be due to that provider not taking Medicaid patients, because that might be their only form of insurance, which has led to 1 in 4 adults not having a routine checkup in the past year. And those were individuals who were between the ages of 45 and 64. So you've heard me talk about Medicaid. Unfortunately, it's not just a Louisiana problem, but here in Louisiana, it is, I feel, almost worse than the rest of the United States. Most mental health providers do not accept Medicaid, and that is due to the lower reimbursement payment rates. If they do accept Medicaid, you will often find that they are currently not accepting new Medicaid patients. So just when you think you found a provider that takes Medicaid, you'll call and try and schedule an appointment, and parents will hear, "I'm sorry, but they're not taking new patients right now," and they'll sit on a waiting list. This is one causing a strain in emergency departments, because individuals and families are turning to emergency rooms for care, or when they reach a crisis situation because they haven't been able to get into their psychologist or psychiatrist. This population just doesn't participate in Medicaid and Medicare the way that other physicians do. A lot of them are cash only. They don't accept any insurance at all. So this is, just another barrier in access. Individuals with disabilities, adults, most of them live on fixed incomes and cannot afford to pay out of pocket to receive behavioral health care services. And then we also see psychiatrists being selective about, whom they're going to treat. So you may find if you're, somebody that has a very mild intellectual disability, they may treat those individuals compared to somebody that might have a more significant cognitive impairment. So there's a lot of issues when it comes to providers, Medicaid, the cost to receive these services. It's just troubling. So part of what I do is, one, bring to light the issues that these individuals and their families face, and then try to encourage providers, our health plans, to one, just recognize that these are the issues, and then try to identify policies, more effective procedures that we can put in place together to create change for this population. So some tips when it comes to communicating with these individuals, just some important tips when you're dealing with them, when you're communicating with their family members. It is crucial that physicians understand just basic humanity, the dignity of people with intellectual and developmental disabilities that have a co-occurring behavioral health condition is critical. And without this understanding, we will never truly begin to enact change and enforce change and policies to better this population. You have to look at these individuals holistically, taking into account all of their skills, all of their abilities, all of the challenges, all of their needs, and taking into account every single corner of their life, whether there's, employment, education, the type of services they receive, the type of services that are available to receive in the community, religion, any other type of belief that they have. You have to look at these individuals again holistically. It's crucial that you fully understand that behavior is a type of communication, as well as temperament, and that they could be exhibiting behaviors as a way of communicating whether something is hurting, whether they don't like the way something is being, done, that it may not be directly related to their disability. It may not be them being defiant. And, you have to dig deep into that behavior to try to better understand what is actually going on with this individual. And then understanding and respecting that these individuals and these families are doing the best that they can with the very little that is available for them. It is very difficult as a parent to try to explain on a daily basis what it's like to live on an island, because that's honestly what it feels like. It's very difficult to be judged, to be ridiculed, and then to go into a medical professional's, office and try and explain this and just get some of these looks. And it's almost like we're being judged, again, by the very professionals that we're going to seek help from. So just being understanding and respectful of the family. We really are doing the best that we can. It is not that difficult and we're going to talk about some different ways to do this, to make treatment accessible to people with an IDD. There are coping mechanisms, there are motivational techniques that can very much be modified to these individuals so that their treatments can be successful, and that these individuals can leave feeling encouraged and with some positive feelings that, one, they're being heard, two, they've got somebody that has a plan that can try and help them, and that they're going to put an effort into their treatment. It's super important for physicians to recognize their limits and understand that you may not be working well with this individual with an IDD. And then how do you look for somebody and help them find a new provider or a new clinician that can better help them, instead of just saying, this isn't working, I really can't see you anymore. Because that's what's happening. What should happen is that it's okay to recognize that this is just a little bit over my head, but I'm going to help you find somebody that can, instead of just dropping them without looking for someone else to sort of pick up where you have left off. So some of the most important things that when I talked with families and individuals, these are the most important things that these individuals wanted professionals to know. They wanted professionals to help them build skills. They wanted their strengths and their successes to be identified by them and celebrated. And then also how to work with them and their supporters, their families, in relationship to de-escalation when they were in crisis. They wanted providers to know that they should be given choices about their healthcare, just like individuals without an ID are given choices. They also would like the physicians to recognize, their age and their capacity when it comes to this. And specifically family members talked about this as well, that the individual with the disability should always be the center point, should always be in focus. But sometimes it might be appropriate to consult with family members if they are attending these appointments with the individual. They might have caregivers or support staff that are providing the day-to-day support for these individuals. So they may not have that family unit. It might be more paid staff, and it might be important to include them in some of the discussions as well. And then also, how can the physician help support this population when it comes to advocacy and self-advocacy skills, and helping and encouraging individuals with IDD to speak up for themselves and talk about, their wants, their needs, their desires, and make sure that they are kept at the forefront of the discussions. So let's talk about some simple communication strategies that individuals, clinicians can put into place to help improve the sessions. It's important that even if there is a family member or a paid caregiver in the room, that the physician or the clinician speak directly to the person and communicates information in a way that the individual understands. And that may take some effort. You might have to break things down into, much smaller steps. You may need to put things in writing and create, bulleted, instructions, or, this is, write out step by step. This is what we're going to do. This is where we're starting. This is our end goal. And here's how we're going to get there. To increase your chances of a rapport with this individual, you need to use their name frequently and refer to them with their name frequently. This has been shown as a technique to help, again, develop that rapport. This will make that individual feel more comfortable speaking directly with you, which will then improve the overall session and hopefully lead to better outcomes. Actively listen without trying to, ascribe any type of challenges that might lead you to a diagnosis. So sit and listen, very actively to this individual. Let them finish their conversations before you try and immediately diagnose them with something. It's super important to sort of plan for longer visits. Sometimes the individual, when they call and set up appointment, it may not be known that this individual has an ID. If you, aren't made aware of it until they come in for the appointment, it might be difficult for that very first one. But going forward, your standard 15 to 30 minutes, sit down, here's what's going on. We're going to make changes. We're not going to make changes. It's not going to be successful. So you need to plan accordingly to allow, a longer visit, to allow the communication to flow freely back and forth. Speaking slowly and allowing the individual time to process maybe what you've said or what you've asked them is important. These individuals with IDD take longer to process and sometimes reply to, a question that's been asked of them. So don't, if you don't get a reply in 3 to 5 seconds, don't immediately jump into and repeat the question again, because then you're just going to confuse that individual even more. So ensuring that they have time to process what you've said and then respond is also important. Again, I talked about this a little bit before, just communicating respectfully, and looking at this individual holistically, taking into account any type of cultural or religious beliefs is super important. It is also crucial to giving these individuals a very realistic picture or description of all of the treatments options that are available. Going through and explaining the pros and cons of each. Even if you don't have time to run through everything in that one visit, providing them with materials that they can take home is recommended, because then the individual, along with their supporters, and it could be paid staff, it could be their family members, it might be a friend, they can then go back with that individual and go through all of them and look at all of the pros and cons before deciding on what treatment would be best. And then another good thing is looking at all those individuals, so their friends, their family members, paid staff, and any other professional that might be a part of their medical team, to be a part of, a more team approach, and making sure that you've got the different systems talking to one another to ensure that this individual receives a full rounded healthcare approach. So adapting the clinical approach is not as difficult as a lot of people think. The data and the reports are very clear that individuals with intellectual and developmental disabilities very much do benefit from the same type of clinical approaches that individuals without an intellectual and developmental disability do. It's proven that it works, but it is going to take possibly some small modifications and accommodations to make it work. So these are just some general tips, and general things that you can do to make some minor accommodations. Simplifying any type of appointments and the referral process is, because that can be very difficult and strenuous. The amount of paperwork that is required often to fill out, if you can send that information and all that paperwork ahead of time to the individual, so when they get there 15 to 20 minutes prior to the appointment, that might not be enough time for them to fill everything out. If they can have, a couple of days to maybe a week in advance to get that filled out, that would be great. Reminder phone calls, if you can't, get the individual, maybe look at a couple of different options to ensuring that they'll show up for the appointment. So it might be, contacting, a family member, it might be their paid direct staff, anything that you can do to ensure that this individual gets there. Doesn't take a lot, but it does make a difference. Again, looking at the extended times, so making the appointment longer is also going to be important. If the individual has some sensory issues, some anxiety, long wait times is very difficult. It will cause these individuals to have an increase in anxiety and other things that can lead to some behaviors. Also, high stimulation environment. So if there's a lot of people in a waiting room, if there's like a quiet room or a space that the individual might want to go to, they don't have to, but having it available will also benefit how the appointment actually goes. And then when looking at appointments, what works best, for that individual, time, location, if they can be, first thing in the morning, or the very last one in the evening time, so the waiting room isn't full, of people. If maybe the doctor's office isn't the best location for them, is there, a central meeting location where this individual might open up and be more, open to communication, feel more comfortable, and just in their environment and be able to benefit better from the services. So anything that you can do sort of above and beyond, booking that 15 to 30-minute appointment. If things run over, the individual's just left sitting in a waiting room. There's not a lot of communication from the staff when you walk in to check in for your appointment. Hey, he's running behind, a certain amount of time off. If you are running behind and this individual struggles, and is a stickler to time, does not like, a lot of people in a waiting room, make sure that the when you check in, let them know that this individual, you're running behind, offer them to maybe, leave, go to a different, area in the office, and come back. So they're not just sitting and waiting. Avoid any, late last minute cancellations, or any type of short notice. So if possible, prepare the individual for change. So if they're coming later in the afternoon, you're already running 45 minutes to an hour behind. Calling them and letting them know that they're running behind before they even leave could greatly benefit that individual. So not just sitting in there waiting, they can maybe stay, at home or stop somewhere prior to the appointment and do something maybe that they wanted to do prior to coming in. Preparing ahead of time for any type of communication needs that this individual has is crucial. Making sure that if they do have a different way of communicating, that you have all of that in place prior to them coming to the appointment. If the individual requires an interpreter, making sure all of that is set up ahead of time so the appointment can go smoothly. And then any type of physical supports that the individual might need, if they have a physical disability as well, making sure that everything is completely accessible, and also addresses any type of sensory needs, will also just help that individual have better success for the appointment. One thing that I hear from families a lot is the need for the doctors to have a better understanding of the system and how these individuals receive support from the systems, understanding how our waiver system works, and how OCDD and the Office of Behavioral Health don't have a lot of communication or overlap. Understanding different acronyms that come with both systems, the different languages that are used across the systems is important. And then understanding all of the community resources that are available to this population and their families. So any, think of, the different ARCs, chapters of the ARC, the ARC of Louisiana, Families Helping Families. All of these local community resources could really be important for families when they're trying to navigate these systems. And then, of course, understanding our disability laws. So the American with Disabilities Act has some very, if you just Google the ADA in healthcare, it has like frequently asked questions. It's got tips and basic, just small things that can be done to improve healthcare access for individuals with disabilities. And then there is a National Association for Dual Diagnosis, or NADD. This group is all about dual diagnosis. They actually have a conference coming up in December. It is going to be online. So you can start by surrounding yourself with like-minded associates. I highly recommend becoming a member of NADD, attending their webinars and their conferences, just to hear, the latest about how, what's being done specifically for this population. And they have a ton of resources that you can access and put some of those, into place in your practice. thank you all so much for this opportunity to be here with you today. I will be around for the live Q&A. But if you have any other, questions for me at any point, here's all of my contact information, my phone number at the office, and my email address.
Hi, everyone, and thank you so much again for joining our panel discussion today. This topic was picked by Tanya, which unfortunately she wasn't able to join us. And she saw that there is such a need for this topic to be discussed. And as we saw in our presenters, there is a real gap between care for this specific demographic. So I want to thank Ashley and Dr. Kelly for speaking today on this issue. I did see that we had a participant raise their hand. Robin, if you still have a question, if you could put it in the Q&A box and we will get that answered. Someone else asked if they could get a copy of the slides, and we will be posting this presentation on our website at a later time, so that will be available. But I did want to dive into some questions, and the first one is for Ashley. Has there been specific techniques that have worked when a professional is caring for your son when he is in a crisis?
Yes and no. I think that every situation is going to be different based on, the individual. And it's important that, a physician look at, just all of the things that they can do, and then recognize that if what they've tried in the past isn't working, that they reach out, ask the family member, ask the caregiver, are there things, tips and techniques that they know of that has worked in the past, and give those a try before just, trying things that, that may cause more harm than good.
Mm-hmm. And I saw in your presentation, you mentioned stigmas and barriers that have prevented people with intellectual or developmental disabilities from seeking treatment. Could you elaborate a little bit on what that stigma looks like?
So it varies from, from person to person, but from the research that I've found is that just overall, the stigmas related around individuals that have a mental health condition do prevent them from accessing things that, people without a mental health condition do, whether it be healthcare, whether it be, community-based services. They really struggle with people understanding fully what their needs are. And a lot of times people use that mental health condition to, it really just becomes the one thing, and it overtakes who they are as a person. And people tend to focus on that more than maybe they're just having an off day, or maybe they have some other type of acute illness. Maybe it's a toothache. Once an individual is labeled with some type of mental health condition, a lot of times that particular diagnosis is always pushed to the forefront, and other things are not even given any type of, consideration. So it does impact, almost every aspect of that individual's life, and it can really be detrimental to that person.
Mm-hmm. Yeah, definitely. And thank you so much for sharing. And also thank you for sharing your story and the hurdles that you've had to jump through, as well as other parents, for seeking treatment for your family members. It's definitely a problem that we really have to shine more light on and get it addressed. So thank you so much. Dr. Kelly, I wanted to hear a little bit about what does help look like from the OCDD Resource Center.
Yeah, so as I said, we have a group of interdisciplinary professionals across the state. We have about 56 staff in the Resource Center. I always tell folks we should change the name because it's not a location anymore. We used to have actually 4 centers that were associated with former supports and services centers the OCDD operated. Since those were privatized or closed. We were able to hold on to the staff, for which we are very thankful. All of those staff telework, so they work from home and they do all of their work out in the field, which means we come to whoever, right? So if we're consulting to a clinician, we meet you where you need us to meet you. There are times that we consult directly to a family or a DD provider when they're not really sure, right? Does someone need to get to a professional? And we meet them where they are. So we have 56 staff spread across the state. About a third of those folks are behavioral health professionals. Most are psychologists. We have a few social workers and we have a couple of master's level clinicians as well. And we really do a lot of different things, but if a clinician is, gets a referral for an individual and that individual has a co-occurring disability and they're not really sure if they are comfortable, right? They maybe they don't want to turn the person away. They're willing to try to provide treatment or do an assessment, but they don't know for sure if they really are going to be making the right decisions about modifications. We are available. I gave that sort of email resource.center@la.gov, so folks can certainly reach us there. They also can contact the DD division of Imperial Calcasieu because James and his staff absolutely know where to find us and how to get to us. So the clinician can really consult in a lot of different ways. We have had clinicians literally work alongside another clinician and sort of like do an assessment together, do some treatment sessions together. It can look like a peer-to-peer consultation, right? Where it's really just the clinician who's doing the treating is providing some information and we are giving them some guidance on some modifications. We've also done things where if a situation was really critical initially, we have had a local clinician actually start treatment and then work with another clinician they could find in the area and sort of transition that treatment to the clinician who is not with the resource center. So we can do that in a lot of different ways. We also, as I mentioned in the presentation, we do lots of different trainings. We can customize training. We can share continuing ed events, and we can also help connect folks to other people who do training because we may not be certified, for example, in MST. So we're not going to come out and necessarily do an in-depth training to an MST team. We can consult to the team, but we certainly can connect people to folks who do that perhaps in other places. So it can really look like any of those things. And sort of my running answer is we will consult to anyone, anywhere, anytime. So we can also go into inpatient settings. So if you're treating someone in the community and they end up in a hospital or a psychiatric residential treatment facility, if it's a youth, and you're maybe not sure of what you can handle sort of when they leave or how to kind of transition, we've also gone in and consulted to those inpatient and residential treatment units to try to use that time wisely to really see what we can learn relative to what's going on with that person.
Okay, great. Thank you for sharing those valuable resources available. We are wrapping up with our discussion, so I wanted to see if each of you could just share one key takeaway that attendees can get out of today's presentation.
I don't know if you want to go first, Ashley, or you want
You
me
can
to?
go.
So I guess my big takeaway is individuals with disabilities have the same challenges that those of us who do not experience disabilities have, and they can, in fact, and should be able to access and benefit from treatment. And there is help. There are people here. We are here to help. We want to help. And so it's more a matter of, just try not to sort of lead with assuming that it can't happen. And there is new research that shows that the biggest predictor of therapy outcomes is not the actual therapy approach. It is the hope and the belief of the therapist that the person can improve. And I think our folks often don't get that. People assume because of the disability condition that perhaps things won't get better and it's just going to be this way. And I think that often derails any approach that anyone can take. So I guess that's what I would say as sort of a wrap up.
Yeah, she said it way more eloquently than I would have. So I'm just going to have to agree with what Dr. Brandon Kelly said.
Awesome. Well, thank y'all so much again for tuning in and for sharing your expertise on this subject that, again, there's not a lot of expertise on, so we appreciate y'all for coming. We are gonna be sharing a survey on Monday in an email, if y'all could please take it. And like I said earlier, a recording of today's event will be posted on our website, hopefully by Monday as well. Thank y'all so much, and we will be having another event in 30 minutes that's aimed for disability professionals. Y'all take care and have a great Friday. Bye.